This Week in Virology, the podcast about viruses, the kind that make you sick. From Microbe TV, this is TWiV, This Week in Virology, episode 965, recorded on December 16th, 2022. I'm Vincent Racaniello, and you're listening to the podcast all about viruses. Joining me today from Western Massachusetts, Alan Dove.
Good to be here, and it is crummy weather here. It's drizzling and intermittent snow, and 34 Fahrenheit, 1 Celsius, and just that raw cold that we get in early winter here.
Yeah, it's been raining all night here. Some parts north New York State, it's snow, I understand.
Yeah. Actually, out in the Berkshires, just west of me. Pardon me.
Oh, there's a cat. Look at that. She's been obnoxiously affectionate today. That's fine. We don't mind
out
cats.
Out in the Berkshires just west of me, they got the whole bunch of snow, and we got a bunch of rain.
Yeah. Well, our guest today is from a place where there is no snow at the moment. He is returning. He is an infectious diseases specialist and professor of infectious and parasitic diseases at the University of São Paulo in Brazil. Esper Kallas, welcome back.
Well, thank you very much, Vincent. Hi, Alan. It's a pleasure to be here again.
What's the temperature down there now?
Yeah, so I just pulled out my weather app here. It's 22 degrees. It's a beautiful day. It's 5 p.m. It's 5 p.m. In the afternoon, and blue skies. Really nice weather.
Sounds good, doesn't it?
Yeah, wouldn't mind that.
Esper was last on TWiV 383, which was in April of 2016, and the big topic back then was Zika virus.
Yeah, that was the virus everybody was. I actually just went back and listened to that episode, and it's from a different time. It's which both it feels like it was a long time ago, and also like it was not a long time ago because of that weird pandemic distortion that we had.
That got in between, yeah. Well, we'll talk a little bit about that. Before we start, I have a couple of announcements. This is your last chance to get a Spike t-shirt. We are collaborating with vaccinated.us. They are providing Spike t-shirts and providing some of the profits to Microbe TV. So go to vaccinated.us and use the promo code Microbe TV on checkout, and that will direct some of the profits to us. They have some unusual, nice new shirts. They have a long sleeve shirt. I just bought one this week. I like long sleeve t-shirts, and they have all different colors and big ones and small ones. They also have a group sales thing, which I used this week. And you should have gotten yours, Alan,
I did,
right?
yes. I got the gift certificate in my email, and I already applied it, and I bought not only a Spike shirt, but I also have the mug coming, so I'll be drinking my coffee spiked.
So you can just put emails into this group sales page, and you pay a certain amount for each one, and then everyone gets an email with a gift card. They can pick out their own size and order it, and you pay for it. So I just bought Spike shirts for everybody in Microbe TV, and you can do the same for your organization as well. And they have now expedited shipping. If you'd like to get it in time for the holidays, there are also gift cards in case there's no time. The gift cards go by email, so that's great. Really nice. So vaccinated.us, we thank them for their support, and Matt there. And if you want to hear Matt, he was on the last two episodes ago. I did a little interview with Matt at vaccinated.us. And also the final announcement for this International Scientific Coordinator position. It's a position based in Managua, Nicaragua, or if you'd like in the San Francisco Bay Area, and you'll have to travel to Nicaragua.
Unless you're there already, in which case you might have to travel to the San Francisco Bay Area.
It could be. Hands-on global experience with participation in local scientific capacity-building activities, program management, and generating publications. You'll work with researchers at UC Berkeley and the University of Michigan, working on arboviruses and respiratory viruses, and help run a research center within the NIH Centers for Research in Emerging Infectious Diseases Network. There'll be links in the show notes for more description and an email where you can find out more from someone at this position. All right, Esper, I know we asked you about your history last time, but it's too long ago. I don't remember. Tell us, you're from Brazil originally, right?
Yeah, from a Lebanese immigrant family. I was born in south of Minas Gerais state, which is just northeast of São Paulo state, where I did my medical school. And then I came to São Paulo, did my residency master's degree. This is something very Brazilian. Physicians, before moving to PhD level, they do master's and then PhD. And then I became a professor here. During the PhD, I did 2 years, what we call the sandwich scholarship at the University of Rochester, New York, where I worked at the Division of Infectious Diseases. Good friends up there until today, and then now I'm at the University of São Paulo, where I became a full professor in 2019, and just before the pandemic started. So that's the brief background.
So in Brazil, is there national health care in Brazil, or is it not yet?
Yeah, it was in 1988 when they approved the new constitution, which is effective till today. There was one of the biggest advances in that constitutional text that says that healthcare is a right to the citizen and a duty to the government. And that was applied throughout the country. It was a big push. Started from a not too equal system that persists until today, but every Brazilian has access to healthcare. And this is not too rigid in a way that we have several immigrants that come here. They also assess the system, and which is not denied to anyone. So it's a universal healthcare. One of the hallmarks of this, probably a good example, was in 1997 when the Brazilian system decided to provide free of charge access to antiretroviral therapy to people living with HIV, which was considered a huge thing around the world because universal access to antiretrovirals was something questionable, especially to developing countries such as Brazil. But our system, protected by this constitution, provided access, which was a major advance in the fight against HIV/AIDS pandemic.
Yeah, I actually remember that. That was right when I was becoming a science journalist. And it was a big story at the time. I didn't really cover it, but I was certainly noticing that Brazil was leading the way on that.
Yeah, and the number of people seeking emergency rooms with AIDS dramatically dropped. I mean, I finished my residency in '93, and back those times, you couldn't fit people in the emergency room, all with HIV/AIDS and a lot of suffering and discrimination. You know the story very well. And then a few years later, those emergency rooms were like few patients were seeking. And the challenge was to diagnose everybody and put them on antiretroviral therapy, which persists until today. But it was a big change, a big impact in the healthcare system.
So this is paid for by the government, I presume, right?
Correct. And this puts the Brazilian government in a good position to negotiate with the big pharma. Right. They come not to buy 10 bottles or 100 bottles, but I mean, hundreds of thousands of bottles, so they can negotiate a better price.
Right.
And the time also pushed some of those drugs into generic market, and then became even cheaper. And I mean, but still, I mean, it consumes a big chunk of the budget. But any math you do, the risk benefit or the cost benefit analysis is always favorable. So you got to invest in treating people.
Right, because if you wait for them to show up at the emergency room, then you've got much more expensive problems that the government still has to foot the bill for.
Absolutely. I mean, one day in an ICU for any given patient would pay an entire year of antiretroviral therapy. So this is something we were able to consolidate. So not even a single politician challenges that model anymore, which is something that goes back in time. I mean, the best thing you can do to intervene in an environment is change the policy. So if you do that, I think you put the seed that's very hard to take the tree out. So I think this is what we should do.
So every person in Brazil can go into a hospital or a doctor's office and have care without paying. Is that correct?
For antiretrovirals, yes. For the general treatment, there is obviously some inequality. I mean, you have some sites like our university is a referral site. So we have highly complex medical treatment, but some states that are more resource limited, they may have problems. So this is something that Brazil needs still to work a lot. I mean, to increase investment, better management of those available funds that are limited, and make it more equal throughout the country.
Right. And we're going to get to the pandemic, and I think that's probably going to take up the bulk of our discussion. But I wonder, since last time you were on back in 2016, we talked about Zika and dengue. I wonder if you could give a little update on where things are. I mean, at that time, the whole Zika microcephaly thing was the big mystery. There were 2 dengue vaccines that we talked about, one of which, Dengvaxia, as I'm sure you're aware, has had a somewhat complicated history since then. So just, how are Zika and dengue in Brazil now?
So dengue, well, let's start with Zika. After we did our show, we embarked on to help a VRC effort to bring a DNA vaccine forward. The VRC colleagues at the NIAID sought to implement a phase 2B study in Central and South America. Even some U.S. sites were participating, and with 2,400 people, 1-to-1 randomization ratio between vaccine and placebo. It turns out after about 8 months of follow-up of those volunteers, only 2 cases of Zika. So the disease went away, which was good. I mean, we suffered a lot. But what happened was the conjunction of environmental and probably biology of the virus and the transmitting mosquito played to the result of the lack of circulation of virus. So we see just few pockets of Zika transmission. I think the latest one was in the middle of Amazon in an urban area around Manaus, one of the capitals, and then it went away. So we've not seen Zika anymore.
So there's probably quite a bit of population immunity to it at this point, right?
Yeah, but that depends on the area you are. I mean, if you're in Northeast, you have some serosurveys with over 80% seropositivity, which is remarkable. But if you come down here to São Paulo area, where the virus did not circulate as much, it's less than 5%. And there are some unexplained environmental factors, I believe, that play a role in there. But just going back to that time, I mean, the impact of Zika circulation was so immense that this is the first time in Brazilian history that natality rate dropped 5.4% in 2016. And there's no precedent in history. I mean, the women got so scared of getting pregnant, they all avoided. In some strata, particularly in Northeast Brazil, in the city of Recife, in the high-income families, the natality rate dropped to 45%. they all decided not to get pregnant 2016. So I never seen anything like this.
Is it returned now, more or less?
Yeah, and the following year became to baseline levels.
Yeah,
I mean,
yeah. But certainly there are a lot of kids now with microcephaly that remains, right? That's a problem? No?
Those who survived, yes, and there are some clinics specialized in caring for the microcephaly babies. There was a lot of complaint that some of those policies were left aside. But so for those who did not have severe malformations or severe compromising of the neural system, who survived, I mean, they still in their families. And in some of those cases, unfortunately, they prompted those families to lose stability. I mean, mother and father divorced, and kids were left alone with their mothers or grandmother. I mean, we see this kind of thing happening. So
what can you expect from a child with microcephaly? Do they have a reduced lifespan, for example?
By and large, yes, and that's because they start losing their ability to respond to even motorly. I mean, they cannot cough well and have other complications due to lack of mobility. So yes, in general, that's what we see.
Okay. And so what about dengue? Do you use dengue vaccine there, and is it controlling dengue?
Yeah. Well, back then there was a lot of controversy about dengue-voxia, and me and my group were really very skeptical about implementing healthcare, and we did suggest not to happen. In fact, in the later times, we saw that it was a bad idea to adopt dengue-voxia, especially in areas where the seroprevalence is lower, because then the immunity of the immunogenicity of dengue-voxia was not too good, and then you start seeing ADE happening all the time.
And that's just for people who just joined us, the antibody-dependent enhancement, and this is the big hurdle with dengue vaccines. A little bit of immunity is worse than none, right?
Correct. And as a disclaimer, I was the PI for a phase 2 clinical trial on another vaccine. It's called TWiV, and it's now renamed the Butantan dengue vaccine, which was brought up by Steve Whitehead in Durban. I mean, those two, they're brilliant scientists. Steve did this, he created this vaccine based on so many dengue variants he had in his lab, and played with those variants until finding 4 who that would represent the 4 serotypes. So this tetravalent vaccine came on board. I mean, he did the phase 1 clinical trial within Durban in Johns Hopkins. Immunogenicity was great, and she even published a very bright and very inspiring paper on a dengue serotype 2 attenuated challenge after vaccination with 100% protection of those volunteers. And a scientist from Butantan Institute back then, his name is Isaias Rao. He's a Jewish scientist here in Brazil, very bright. He was the director for the institute, came to the NIAID and said, well, we're interested in this vaccine. And Butantan decided to bring the program down here. Another director that followed, I'm mentioning him in particularly because he passed away 2 days ago at 95. So it would be nice to remember his name at this moment. Jorge Khalil, who is the following director at the Butantan Institute, decided to move the program forward, and we started a phase 2 clinical trial. Vaccine was well tolerated, immunogenic, and that came out in the Lancet Infectious Diseases a few years ago. And as a follow-up, we started the phase 3 clinical trial. That clinical trial involved a little bit more than 16,000 volunteers, to 2-to-1 randomization ratio across 16 sites in Brazil. And the preliminary results were announced yesterday. I mean, the result was pretty encouraging, with 79% effectiveness. So this efficacy was very nice, but there are a couple of problems with this vaccine. The first is we only had dengue 1 and 2 cases during the follow-up of the first 2 years. So we lack phase 3 and 4 cases. And the second is the data has been analyzed for the first 2 years. So there's a lot to do, but it's a promising vaccine that we are very enthusiastic about. And this is very encouraging, because if this vaccine has proven efficacious to prevent dengue 3 and 4, and the protection is sustained over time, it's a one shot. Just like one shot, it will be done. And that could be a solution. But besides that, we're not using dengue-pox yet. So we don't have any dengue vaccine programs that are effective at the moment.
And in those trials, you haven't seen any evidence of ADE, antibody-dependent enhancement, right?
No, for this trial and 2 years of follow-up, no. But you got to be cautious.
Right.
You got to go back, look, and even the equivalent to the FDA here, Anvisa, they require at least 3 years follow-up after any vaccine trial on dengue vaccine candidates. So you got to be on the safe side always. Primum non nocere.
Yes. So roughly how many cases of dengue are there in Brazil every year?
This year was more than 1 million, and was a big year, although it was spread throughout the country. So there was not a particular region where we had too many cases concentrated in a huge outbreak. But from the epidemiologists that I've been talking to here, they are not very optimistic about 2023. So we are more cautious, and the surveillance needs to work, because we need to detect those outbreaks at early stage to implement mosquito control interventions. Otherwise, we may have a bad year.
Did you say there were mainly serotypes 3 and 4 in Brazil? Is that correct?
So that was the problem. On the opposite, I mean, we had only dengue 1 and 2 serotypes of dengue in the past few years in most places where the vaccine clinical trial was implemented.
I see.
Which was all the Brazilian regions. But you never know what's going to prevail in a future outbreak. This is something that I truly don't understand. Why? I mean, what drives the one variant over the other? I mean, it's
and I've forgotten what reservoirs do you have for dengue in Brazil?
Well, mostly the dried eggs of mosquitoes, because they stay in the environment for a longer time. So sometimes, in some cases, a few years, and also the introduction of variants that come from other places.
I think we did not too long ago on TWiV a paper about yellow fever in Brazil, if I remember. So what's the story with yellow fever?
So yellow fever is a disease everybody knows. It concentrates in it's a monkey disease. I mean, it's in the virus circulates in primates in Africa and South America. The Brazilian story was about a variant genotype E South America that was isolated in north of Brazil in 2013. And that area around the Amazon basin is where the vaccination efforts are mostly concentrated. So virtually 100% of people living there are vaccinated, because we know, I mean, yellow fever is a true disease. I mean, it kills people. And for those admitted to the hospitals, The death rate is at around 40 to 50%, despite we have all the support. It's a really bad disease, bad disease. But what the people working on virus isolates, especially from primates, noted was a route they described of this virus coming from north towards Midwest Brazil and towards Southeast Brazil. And they can even calculate the speed the virus travels at 1.7 kilometers per week, because by detecting the virus that's being transmitted, it's an episodic transmission. And then they were able to say that around 2016, we would run into problems because the virus would approach areas where the vaccine coverage was lower. So the first outbreak was detected in 2016 in northeast of Minas Gerais state, in Espírito Santo state. Minas Gerais, where I was born, despite the fact the vaccine was recommended by the Ministry of Health in that region, the coverage of vaccine for yellow fever was, in some places, 40%. And there was a big outbreak, hundreds of cases, many people died, 2016, early 2017. And according to the state of São Paulo epidemiologists, they told us that the virus would come down in the direction of São Paulo City, a big metropolitan area, in the end of 2017. They would calculate each city. The virus would come based on the speed it would spread in monkeys. And there is an interesting story. They said one city called Jundiaí, which is about 100K, about 60K from São Paulo. They said the virus is going to come there in the last week of August 2017.
Based on when the monkeys were coming for them. Yes.
Yeah. First week of September 2016, there is a monkey that drops dead with the virus. I mean, they missed by a week.
Yeah.
And the virus was coming. So the state surveillance system, very bright and working, very devoted people, they said, well, this is going to come through the north of the city. So let's go there and start vaccinating everybody. So they deployed this vaccination effort in the outskirts of São Paulo, in the north area where the virus would come. And they obtained 85% coverage. Despite the 15%, the 85%, those 15% allowed the virus to be transmitted in the area. There were like 530 cases. Mortality rate 40%, and the virus came close to São Paulo, northbound, circulated through the forest areas around the city, went south. It was a major outbreak, and our hospital was the referral site to have patients coming.
And why weren't these individuals vaccinated? Because not everyone gets vaccinated? This is one reason. The common thought is, well, there's no yellow fever here. Why should I care?
It's not raining. I don't need to take my umbrella. Yes.
Yeah. Exactly. So, and there was another story. When the cases came, we did not have enough vaccines. So
right.
the state decided, well, let's vaccinate in the surrounding areas. And even at some point, after the data from the Fiocruz colleagues, they said, well, let's use 1/5 of the dose, what they say dose sparing regimen, to vaccinate more people. And even that was also used in Congo and Angola afterwards, because we did not have enough shots. So in the beginning of this vaccination, Vincent, there was a rush to the vaccine clinics. The stories are amazing. I mean, they would flock around the vaccination spot. There was confusion in the lines, people jumping over the wall to get in, to get vaccinated. There was an episode that a bunch of criminals kidnapped one nurse with a vaccine box, took to their community, and put everybody in line to get vaccinated.
Oh my gosh.
I mean, it was this craziness until there was news saying that one 60-year-old woman died of vaccine. I mean, visualization of vaccine strain. Next day, nobody in the lines anymore.
Sure.
There was everybody left the line.
Yeah.
Nobody would come over. And nurses would stay there with their syringes filled with vaccine. Nobody would take it. So we needed to go back and on campaigns, talk to people that there was these are rare cases, and there was no reason not to get vaccinated.
Yeah, sure.
So these iconic examples make such a huge impact in the perception of the society and the community and the population that we still don't know how to deal with.
This is risk communication is a huge challenge, and with a vaccine like our current yellow fever vaccine, I mean, yeah, you can't point to that and say, oh, that wasn't caused by the vaccine, because in fact, this particular vaccine does have that potential. And then, yeah. Yeah.
So then we caught up the coverage of vaccination in the São Paulo area went up to 80%. But fortunately, we did not have the vaccine. The yellow fever virus did not go urban. So it stayed sylvatic transmission. And how we can say that? By the distribution of cases, but also the male to female ratio that was 4-1, which is one of the hallmarks of sylvatic transmission instead of urban transmission.
Interesting.
Because the men are working in the forestry jobs and the other places that are at the interface with the sylvatic reservoir, which is the monkeys.
Yeah.
Correct. Yeah.
Oh, cool. By the way, I remember we talked about this when you were on for Zika. Was there any evidence that Zika virus has gone into non-human primate populations in Brazil?
There are some reports, and colleagues from São José do Rio Preto were able to isolate at least the RNA from some animals. Although we don't know how stable it is in these reservoirs and how they can maintain. I would be a little bit. I would be surprised if there was an effective reservoir, because I mean, there was no Zika cases. There are no Zika cases anymore. Yeah.
So this discussion is fascinating for me, because here we have, infectious disease physician in Brazil. You're seeing totally different infectious diseases than we see here, right, in the U.S., because it's geographically different. We had Zika, dengue, yellow fever, and there are others. What's another one that you see that we would not see here?
There are a few Mayaro cases that came from Brazil, but those cases are rare. And for those that we had the opportunity to see, they were mild. The other thing that we saw that in January 2020 were two cases that came to our ward with suspected yellow fever, and turned out were two variants of arenaviruses that were transmitted to these two individuals. They developed a hemorrhagic severe disease, and both passed away. And we were able to isolate in the next generation sequencing in their plasma samples. Those two are one of them at least is published from our department, and but it was a single case. So I think these spillovers happen all the time. I mean, with the technology coming closer and more easy to assess, we're going to make these diagnoses more and more. Of
course, one of the infections which you did have that we also had was monkeypox. You had a lot of monkeypox, right?
Yeah. So monkeypox came to São Paulo in August. It was a big outbreak. Now we hardly see cases. They are very rare in our region. Very interesting for several aspects. And we had a similar wave as New York or big cities in the U.S. But monkeypox, to me, it came and found the highly vulnerable individuals in our region for sexual acquisition. And I think monkeypox is a surrogate marker for exposure to STIs. And we should, I mean, we need to do so much work to define who is highly vulnerable. Monkeypox transmission did this for us. And I think using a serology that would identify natural exposure to this virus would be an interesting tool to prevent other STIs.
Have you vaccinated against monkeypox at all?
We don't have vaccines here yet, Vincent, unfortunately.
Wow.
So it's been brought under control just by educational efforts then.
Oh, well, in virus transmission exhaustion, I think, right. To highly vulnerable people. We don't know what's going to happen. I think we're still going to see some bumps in the curve as we approach times where parties are more frequent, such as New Year's and, Brazilians.
Carnival. I was just thinking it's coming up in February, right?
Yeah.
Okay. All right. So let's talk a little bit about SARS-CoV-2 and COVID-19 and your experience in Brazil. Looking back, 2020, when did you first get wind of something new happening?
Remember I told you about the arena cases that we had in our ward, and it took us so much effort. And we are three full professors, and one was involved in administration. The second one was involved in these arena cases. And then I said, well, let me take a look and be in charge of the SARS-CoV-2, this interesting virus in Southeast Asia. So everybody thought it would be like SARS 2002 and would be a restricted outbreak. Nobody gave too much attention, but I started go over it and we put together a crisis team at our university just to be prepared ahead of time. And that was end of January, where cases start sparking in Italy and Germany. And then I think a few cases in the US as well. And then early February, I have a patient who lives with HIV, and he moved to Milan. And then he dropped me a few video footages where he went to the supermarket. There was no food. People were out of the streets. And then I start getting scared. I think something is really bad going on there. And then because politicians would not talk much about it, if you remember. And I think
there was a January TWiV episode that was titled "This Could Be Bad." 2020.
Is that right?
It was called "This Could Be Bad." I think was the actual title of it was in January of 2020. I was not on that one, but I remember seeing it saying, that's about right.
Yeah, coronavirus update. It could be bad. Yep.
And I remember politicians would not touch a word about it. But then I after I saw those footages, I remember talking to a colleague from radiology who is originally from Italy. He had a friend from the pneumology department in Milan, and he put us on the phone. The guy was freaked out. I mean, he just said, "Get your ICUs ready. You're going to get a wave hitting there anytime soon." Because we don't have beds for ICU anymore, in the ICU anymore. We're admitting patients in the operating rooms. I mean, they're taking the anesthesia machines for life support. And then we convened the group and said, well, if this is happening there now, and according to the wave they had in Italy, we have about 2 weeks to prepare. And there was this rush here of buying stuff and buying ventilators, and all the frenzy started. But was 2 weeks ahead. And the first case is an imported case from Milan, from a Brazilian who was diagnosed in February 26. And from there, everything changed. The first death occurred about 2 weeks later in São Paulo, and it was a spiral of events, and there was a series of things adopted by the state of São Paulo by stopping the business, decreasing public transportation. It was not locked down, but was decreasing transportation. But people were so afraid that the streets were empty, complete dead empty. I mean, you would walk out of your house on a night. I mean, you could walk in the middle of the highway. I mean, nobody was there, and that was the spirit back then. So then we start having those cases ramping up in the second week of March, and our big wave was March, peaking in, if I'm not mistaken, July or August, and then coming down. The São Paulo wave was what they were talking about back then. It was a flat wave. I mean, because of this decrease in mobility that was implemented in the state. So we did not have the same peak as New York, where I heard from colleagues that, the system went into collapse in, I think, early February or early February. So our system was able to hold on in São Paulo. But there were some areas in Brazil that there was a tragic events happening.
So I'm looking at the cases for Brazil. Looks like 1, 2, 3, 4. Now you're in the fifth wave, really. It's going up. But the big one was in January 2022. Big spike, bigger than any before. And you've had 692,000 deaths and 35 million cases. It's a lot.
It's a lot. But the case counts, I would put a grain of salt because our system was not ready to report all of them. So I think you need to look at cases of hospital admissions and deaths and life expectancy in excess of deaths. I mean, they represent more what happened. Yeah. And we were hugely affected by SARS-CoV-2.
Yeah.
When did you develop testing capacity?
That was another ordeal because we did not have enough. The importation was very competitive, and even the mobility of those goods over borders were highly compromised. So we never had enough tests to support the load. Things got a little bit better with the availability of antigen detection tests, rapid tests. And I even have in my office here antigen tests, which I think are great tools, not only for SARS-CoV-2, but any other infectious diseases.
Right. And in terms of the government response and support for the response, I mean, I gather Brazil had a very similar situation to what we had in the U.S. Not to put too fine a point on it, right?
Well, I think some of the people in the central government were inspired by some of the U.S. positions. And I think we need to do a critical evaluation going back in time. I think that chloroquine thing and, ivermectin, until today, I mean, there are still people pushing that agenda. But unfortunately, now they are restricted to very minor pockets. But we had big problems. I think the most notorious case we had was the wave in January 2021 in the Amazon. Mm-hmm. I mean, there is a city called Manaus.
Right.
And,
yes.
And that was the big spike caused by the P1 variant described by the colleagues at the Tropical Medicine Institute here in São Paulo, University of São Paulo, Esther Sabino, Nuno Faria, and also in Japan, where they also described cases, imported cases from that region. The explosion of cases happened by several factors. One of them was the easy of the decrease in the number of cases in the end of 2020, and people was were sick and tired of the pandemic. And that administration of the state decided to decrease they lifted and enforced interventions for transmission. So there was just end of the year where there is a lot of business going on, people going to the shops, and then there was the gamma variant spreading that peaked in early January, and the rush to the hospitals in a region where the number of beds are limited. Resulted in a tragedy because even no beds enough. And even in some moments, the oxygen ran out. We have a colleague, Ho Ye Lee, from our department. She was volunteering in the region, and she described one afternoon there were about 25 people in this ward, some of them in critical stage, all receiving oxygen. Oxygen ran out, 4 died in a few minutes, and people were crying, and they did not know what to do. And when this news spread here in Southeast, colleagues of mine, they couldn't contain the tears because, we've been working against this all along, and this happening, was unbelievable.
Well, I remember, I think it was late 2020 or in like one of the first 2 waves when Daniel Griffin was still on regular TWiV, when we hadn't spun him out into a separate clinical update. He was talking about concerns about oxygen shortage in New York hospitals. So it was not a unique Brazil problem. It was just the demand was so great that the suppliers couldn't keep up.
Yeah. There are so many stories about this pandemic and what we went through. I think we need to do an effort not to let people forget.
Yeah.
Because otherwise you easy on these preparedness against future pandemics. So we need to be very careful about it and maintain our memories.
So how is it now?
Number of cases have much declined. We had a recent spike a few weeks ago, but most of cases are mild because the vaccine adherence in the country is pretty good. 80%, more than 80% received the basic 2-dose vaccination. We're trying to go above 60% for the booster, 3rd dose, and the 4th dose still very low. But there is a push to increase vaccination coverage. What we see is another disease, I think. The new phase of COVID-19 are very, immune-compromised people that develop chronic COVID and very, very hard to clear the virus. And those with advanced age, but they still coming in and out all the time. And every hospital has a few of those cases, so it's a different disease. It's the disease of the immune compromised.
Do you what vaccines have you been using in Brazil?
We used in the first wave the CoronaVac, the Sinovac inactivated vaccine that was brought by the Butantan Institute.
Okay.
Then we used a lot the AstraZeneca that was brought to Brazil by Fiocruz Biomanguinhos in Rio. And they are, if not done, they're almost done with their capacity to produce from head to tail the vaccine. The country imported a lot of Pfizer doses. Plus not as much, but a significant amount of the Johnson & Johnson.
Okay. You don't make any vaccines in Brazil? Any COVID vaccines?
Well, the AstraZeneca.
The AstraZeneca is made there? Okay.
Yeah. But we don't have the bivalent yet. They just came in 2 cargos, 60,000 doses, which is
Nothing.
Too little, but they're coming in. The plan is to implement the vaccination to the most vulnerable people, such as immunocompromised and high and advanced stage groups.
So when you do your vaccination, you're using different vaccines, but is it mostly 2 doses and in some 3? Is that what you do?
No, it's 4 doses for everybody.
4 doses.
I mean, that should be. I mean, but I think I would be happy if the adults, at least the adults, had at least 3 shots.
Right.
Yeah.
How
because we still see a few cases of people with 2 shots that develop severe forms of the disease.
Are they mostly older or not?
Mostly older, but even a few young people that developed more severe forms of the disease with 2 shots.
Is there any? Do you have any antivirals available in Brazil?
We do, although they came too late. The remdesivir came first. Well, before remdesivir, I mean, early 2021, a bunch of colleagues, including myself, start using convalescent plasma at the early phases of the disease. And that was based on the Liebman paper from a group of colleagues from Argentina. I think it was one of the brilliant papers that I saw during this pandemic. Limited resources, this is what you got to do in transferring antibodies, but at early stages. We did in Sao Paulo one big clinical trial with 128 individuals at late stage disease with convalescent plasma. Was a complete failure because I think we were lured by the long PCR detection in these people. Because, ICU patients, PCR positive, we thought, well, the virus is there. We should have heard Vincent Racaniello
so PCR
saying,
positive is not virus.
Yeah. But that we were desperate.
Sure.
So we did the study, complete failure. And but started with convalescent plasma. So many of our colleagues used. And then remdesivir came late in the year 2021. And again, we went through the process of learning that you got to be early to be better. And now too late. Paxlovid it became available last week.
Wow,
it's too late. And there is also the Merck drug molnupiravir, but the efficacy at 30% or 40% is not very encouraging.
And monoclonals, did you ever have those?
Just at the private sector for people who were wealthy enough to get them. They worked. I'm an enthusiast of monoclonal antibodies for infectious diseases, but this, I mean, the escape variants, just hurted the field. I saw this week that there was one effort. They got a donation of Evusheld in one institution and said, "Oh, this is too late."
Yeah, it doesn't work.
It doesn't work anymore.
It's too bad. Well, it's interesting to see how different areas have been impacted by availability of what you need. It's really unfortunate, and maybe next time we should have a better way of more equitable distribution of vaccines and antivirals, right?
Yeah. And maybe be a little more ready for it, but
Did
Brazil do a lot of masking during the pandemic?
A lot.
Yeah.
Until today, I mean, our city demands masking at public transportation in public buildings, although compliance to those recommendations are not very. I mean, it's not being enforced as used to.
Yeah.
My family, we do have a shop in our hometown, and my sister and my 2 sisters and brothers run. And about 4 weeks ago, they called me and say, should we re-implement masks? And with those surge of cases in Europe, United States, and then two weeks later here in Sao Paulo, I said, just go ahead and do it because, let's do some prevention. And the shop is the only one in the city implementing mask usage.
Yeah,
and
Esper's
so
shop.
are you seeing other viruses resurging the way that they have been in some other places like RSV? I know we're hearing a lot about RSV now in the U.S. and there are concerns about what's being called the triple-demic. I'm not really sure I endorse that term, but are you seeing any evidence of anything like that?
Oh yeah, our RSV wave usually starts in February, going through May, and we saw cases popping in some of our cases here. I think what's changing, Alan, is the fact that these assays to detect different pathogens at the same time are really useful, and so just go back in December 2021, when we had the Omicron wave here, huge number of cases that went on until March or so, peaking in January 2022. Some of the sites were running those assays in a subset of those individuals. Then we detected a wave of H3N2 at the same time in parainfluenza 3. Who would know these viruses were co-circulating with Omicron? And I think we have a great deal to understand ahead of us. How is the transmission of these other respiratory viruses and what they really represent? Because it's very common to see a given individual coming in with upper respiratory symptoms, and then you detect, influenza, but then comes rhinovirus together and enterovirus in the nose. What do you do with that? So we don't really understand.
And previously, in 2019, you wouldn't necessarily have been running this whole battery of tests, right?
Yeah. It goes back to the times of swine flu, 2009. So in 2009, we also had a wave here. I remember crisp and clear. There were no influenza detection tests available. So these things, they change habits and probably push the knowledge forward. And I think what you described is what's going to happen with respiratory viruses.
What's the normal flu season in Brazil? When would it start?
It starts in the cold months. It's about May, spanning through September, October.
Right, because your seasons are inverted from ours, right?
Yeah. And so maybe you also have another surge of COVID or SARS-CoV-2 infections then, because the cold months, right? That's what we're seeing here in New York.
Yeah, although it's expected in mid-2023. So let's see what happens with it. It's too early to say.
Yeah.
This virus has taught that we cannot predict very well these things.
So would you say that in Brazil, the pandemic is over?
I don't believe so.
Well, here our president said it was over. So.
Well, it's easy to say on paper.
Yes, of course.
Well, and I think we're getting to a point where, with this virus endemic everywhere now, at some point we do have to stop calling it a pandemic, even though the virus hasn't gone away, right?
Well, sure. Influenza, we don't call a pandemic after so many years, right? And so,
yeah.
But
I think to come to this decision, it's something that I learned with Vincent when he gave a talk a few months ago at our department, that you got to have specialists to make that decision, not politicians.
This is true, yeah. Unfortunately, the WHO is the one who declares the pandemic on. I don't know if they say it's over or not, but they certainly say it's on. Anyway. Last thing, let's talk about, you have a new job you're going to, right? Why don't you tell us about that?
Yeah. I was invited by the future governor to take over the Butantan Institute. Butantan is a 120-year-old institute in the state of São Paulo, located in the city, and the biggest vaccine producer in Brazil. So he has a portfolio of vaccines that provides 60% of doses that are bought every year by the Ministry of Health. So this is a new challenge, and I'm very excited about it because these challenges make you learn more and perhaps helping to contribute to ameliorate suffering and prevent infectious diseases.
So you told me you're still going to see patients, right?
Yeah, I think it maintains you close to reality.
Yeah. So that where you are there in your office, you'll still have that office. Is that right?
Yeah. I don't plan to leave.
Okay.
Because it always a breath of knowledge when you see someone and brings you more close to reality. And we did study for all these years to do what we do, and it would be a shame. I mean, it's a good thing to keep your sharp.
I think another TWiV guest, Tony Fauci, would agree with you. He's and he has that experience of running an institute while still practicing. So
yeah,
well,
seems to be a common habit.
Tony's an icon to every infectious diseases specialist, and I hope him the best.
I am really looking forward to hearing what he has to say when he's finally unchained, because he has been so circumspect in interviews, and he's leaving NIAID, but he's not out the door yet. And Science just had a big profile and interview with him, and he's still choosing his words very carefully, and I'm really looking forward to that.
Yeah.
Esper Kallas, University of São Paulo. Thanks so much for joining us. It's been a pleasure.
Oh, it's always a pleasure. I mean, I keep hearing you every week. Thanks for what you do. And I'll repeat something that I said to you prior to this interview. I think TWiV was one of the most, if not the most, biggest source of good information through this pandemic. I mean, we learned so much hearing from you, following Daniel's insights and discussions, the paper discussions, critical eye to the wrong concepts that were out there. And in many instances was a source of inspiration and for all of us that were working on a day-to-day basis. So thanks for what you do.
My pleasure.
Thank you.
I'm glad it was useful. Yeah, I've been to Brazil twice, and it's a lovely country.
I've never been.
And the people are wonderful. I told them that. I said, they're so friendly. It's just lovely. And I hope to go back again. Yeah.
He's a great guest. I can't believe it's been that long since we had him on.
It's like almost 7 years.
But at the
right?
same time, I mean, it's like, oh, was it only 7 years? Oh, wait, it was, yeah.
So 7 years is a long time. But as you said, with this event in the middle, it makes
this weird time twist that happens in 2020, and it's like, oh, it passed in the blink of an eye, and yet it lasted 1,000 years, and
It really puts a big wedge in.
Because all of our social constructs of what happens when got just completely twisted around. Yeah.
Yeah, it's highly unfortunate.
But
so let's do a couple of emails, Alan.
Sure.
Why don't you take that first one?
Okay, so where are we? Alex writes, "Hi, gang. Love the show. Thanks, as always, for bringing us real science with the meat on. Just wanted to add my understanding on what went wrong with the vaccination rollout that caused people significant injuries in some places, and why there's a difference in opinion on vaccination method in different countries, important for an international audience. When you have people with plenty of experience administering vaccines, the guidelines in many countries are simply to deliver the vaccine without first drawing back on the syringe, as this extra movement results in increased local bruising and discomfort over the following days, which puts people off coming back. When you have people with less experience or different experience, there can be a higher risk of injecting IV instead of IM. Normal policy here would be so intravenously instead of intramuscularly. Normal policy here would be to mitigate the risk by taking the extra step of pulling back on the syringe to ensure you don't get blood before injecting. However, during the as fast as possible vaccine rollout in 2021, for example, here in the UK, the first policy seemed to have remained in place while enlisting the assistance from less experienced vaccine givers, resulting in severe injuries to the most pro-vaxxers who were first in line. The experience described is very different to the normal but rare documented adverse reactions to the vaccine. For example, getting a metallic taste in the mouth within the first minute is consistent with fast delivery through the bloodstream. Long-lasting pain throughout the body was completely disabling, and the politicization of vaccination made it extra difficult for many to be taken seriously and apprehensive about becoming too vocal for fear of having their experience used by the anti-vaxxer camp. These injuries were caused by mistake and should not be confused in any way with a safety issue with the vaccine itself when delivered correctly. Hope this helps. Alex, an excellent point.
I wonder if, so as you know, there is a certain frequency of myocarditis associated with vaccination. And I wonder whether it's because of this small fraction where it may get into the blood vessel.
Maybe.
Right? And whether pulling back on the syringe would mitigate that, but no one's really done the study to look at that. So
yeah,
we'll never know.
And this point about experienced versus less experienced vaccinators certainly makes sense.
There was a paper last year that in mice anyway, where if you put they used mRNA vaccine. If you put it intramuscularly, there was no myocarditis, but you injected it intravenously, then you got substantial myocarditis. So that may be the best we're going to get on that.
Yeah.
All right. Heli writes, thank you for another interesting and entertaining TWiV 954, which I only got time to listen to today. With reference to what happens to the environment if we eliminate some or all mosquitoes, it might be worth taking a look at this book chapter. And we have a link to Killing Mosquitoes, Think Before You Swat. And as Alan would agree, it's fair to say that mosquitoes have inflicted more misery on human beings than any other animal.
Yes.
So this is all about whether it would be a bad thing to eliminate all mosquitoes.
I love the last. Can we learn to live with mosquitoes without them ultimately killing us or us killing them, thereby allowing us to enter a new age of mosquitopia?
Hella is at the Australian Infectious Diseases Research Centre in the University of Queensland and has a number of quotes at the end of the email, including prediction is very difficult, especially if it's about the future. I didn't know that Niels Bohr said that.
I didn't.
Did you?
I thought that was Yogi Berra, but okay.
I did too. And we have Jonas Salk. It is said
but
that
as Yogi Berra himself said, I've never said half the things I've said. So
Jonas Salk said, it is said that to await certainty is to wait eternity. And Dixon de Pommier writes, historians even have problems predicting the past.
Yes.
It's not predicting when it's the past, is it?
No, I guess that's post-dicting.
All right, you're next, Alan.
Neil writes, TWiV hosts, I recently listened to TWiV 956. In response to a question in a letter from Lisa about the relative merits of monoclonal versus polyclonal antibodies, Rich Condit, at about 1 hour, 20 minutes, 18 seconds, made a series of comments on the potential value of convalescent plasma. Unlike his generally detailed and incisive comments about experiments involving the characterization of viruses and viral infections, Rich's remarks about therapy with convalescent plasma were less detailed, did not directly reference specific studies, and did not address what sorts of characteristics such studies should possess in order to be reliable guides to case management. The latter point is important because the results of studies on the therapeutic utility of convalescent plasma from individuals who have survived COVID-19 are complicated to interpret. Your former guest, Arturo Casadeval, who Vincent mentions and is CC'd in this message, is one of the chief proponents of the therapeutic potential of convalescent plasma for COVID-19. Arturo has extensively studied, in one sense or another, antibody therapy for COVID-19 and other infectious diseases. He has repeatedly emphasized that this treatment modality is most likely to be effective for patients with SARS-CoV-2 when used early in the course of infection, and when the antibody titer, measure of concentration, is above an empirically established threshold for neutralizing activity, which does not imply that non-neutralizing antibodies cannot contribute to immunity. Unfortunately, many studies, including some randomized clinical trials, did not adhere closely to these sensible but not always easily followed guidelines. In fact, I seem to remember Arturo talking about those exact issues on an episode at some point.
That's correct.
Below, I provide a link to a 2022 article that provides clinical practice guidelines from the Association for the Advancement of Blood and Biotherapies, COVID-19 Convalescent Plasma. The next link is for an article entitled COVID-19 Convalescent Plasma and Clinical Trials Understanding Conflicting Outcomes. Two considerations worthy of note. One, immunocompromised patients may be more likely to benefit from treatment with convalescent plasma than immunocompetent patients, gives a citation. And two, there is experimental evidence to suggest that antibodies in many convalescent plasmas can neutralize Omicron variants, gives another reference. Another significant point is that if convalescent plasma for COVID-19 used early and with appropriately high neutralizing titers for SARS-CoV-2 is not therapeutically effective, it would be important to understand why that is the case. There is no obvious mechanism to account for polyclonal neutralizing antibodies for the virus not being intrinsically effective for protecting against disease to some meaningful degree if used when most appropriate and at adequate titer. Of course, otherwise effective antibodies could fail due to other components of plasma that might somehow counteract the benefits of the antibody. Given the documented risk of viral escape from monoclonal antibodies in COVID-19 and data from many studies of antibody-mediated neutralization of SARS-CoV-2 and other viruses, there is reason to expect polyclonal antibody populations to offer a lower risk of such escape based on mutation-driven antigenic variation. On this point, Lisa's expectations are consistent with standard immunological thinking. Best regards, Neil Greenspan, who is professor of pathology and senior editor of Pathogens and Immunity at Case Western. Thank you, Neil.
So I agree with a lot of these things.
Yeah.
And of course, monoclonals are susceptible to evasive variants.
As we
right?
just discussed with Esper, yeah.
Yeah. So convalescent plasma would be preferable. So early in the pandemic, we had nothing, so convalescent plasma was tried. And as Theodora Hatsuano pointed out to me last week, we didn't know what titers to use, what neutralizing titers. And we used too low a titer, and that therefore it wasn't effective early on. And then, of course, other interventions came around, so there was less of a need to use convalescent plasma. But, of course, when you have monoclonals failing, that might be a time when you might want to use it.
Yeah.
So I don't know what the status is now of anyone using convalescent plasma, right?
Yeah, it just fell off the radar completely. And I think the combination of negative results from trials that had, in many cases, these various problems, unknown titer, et cetera, being given too late, and the availability of alternatives, why not just give Paxlovid or what have you? And maybe even a shortage of convalescent plasma. I don't know if people have kept it around or if they're still collecting it.
Yeah. So the next email is actually from Arturo Casadeval. Mm-hmm. He writes, I listened to the episode and agree with Neil Greenspan that some aspects of the discussion about convalescent plasma are not right. A lot of work has shown it to be effective if used early, and it is currently recommended by IDSA, AAP, and ICEL for use in immunosuppressed patients. As we have lost all the monoclonal antibodies, CP, convalescent plasma, is now the only antibody-based therapy available. At Hopkins, we stopped using monoclonals 2 weeks ago and are now relying on convalescent plasma.
Okay.
So there you go.
There we go.
Hopkins
Somebody's using it.
I think it would be good if this topic was covered again in more detail. I would be happy to join you guys again and chat about what happened since I last visited in early 2021. Here's the Hopkins study, provides a link, establishing efficacy of convalescent plasma in outpatients, and another link, a preprint from our group hopefully soon to be published in Nature Communications, showing that if you give convalescent plasma in the first 5 days of infection, it's as good as monoclonals for a fraction of the cost. Okay, Arturo, we'll take you up on that.
Yes.
And get you back, and you can tell us all about it.
Get an update.
I'll shoot you an email.
And you can tell I don't read ahead in the emails before the show, because otherwise I would have seen that coming and not been blathering on about I don't know if anybody's doing it. Yeah.
And then Neil wrote back, the same Neil, who's saying that, monoclonals are not used anymore. So that's that. Can you take Brenda's?
Okay, Brenda writes, came across this on Twitter. What is this link? Somebody tweeting, some anti-vax stuff that I won't repeat. So claiming immune damage to vital organs after vaccination.
So a little backstory here, Alan, is that the science paper came out recently showing that an mRNA vaccine against all the flu types can work, right?
Right.
So this is, and in fact, that's Scott Hensley. He's going to join us next year.
Cool.
To talk about that. And of course, this guy who is not a virologist is saying this is going to cause
some random schmuck is claiming autoimmune damage.
There's no evidence for that, right?
Yeah, no. And Brenda says, I've been listening to Immune for a while, and it's where my understanding of how the immune system works and how mRNA vaccines are handled by the immune system. The above statement seems quite at odds with the understanding I've acquired. Can you clarify? The understanding you've acquired from Immune should be at odds with this statement, because this statement about autoimmune damage to vital organs from an mRNA vaccine is just preposterous. I mean, there's a lot we don't understand about the immune system, but this doesn't make any mechanistic sense from...
No, you're giving an mRNA encoding a foreign protein.
Yeah.
You're going to make antibodies against the foreign protein. If it so happens that some of those antibodies cross-react to our tissues, you would get autoimmune disease. But among the hundreds of millions of doses of this vaccine given, there's no evidence.
There's no evidence of that.
And there's no evidence. There's no reason to think it will happen with the influenza vaccine, which is the hemagglutinin protein, which we've been giving to people for years.
Giving to people since the 50s, and nobody's had a problem with it.
No.
I mean, it is absolutely true that there are antigens, including viral antigens, that can stimulate antibody production that's close enough to a self-antigen that it then leads some people to go on to develop an autoimmune response. That's one of the reasons we do clinical trials and preclinical analyses on these things is, that's a concern, and that's something that is looked into, that's drilled into in all those trials. These particular antigens, there's absolutely no reason to think that will happen, and quite a few reasons to think it won't.
This is an example of someone who just wants to get attention in social media by predicting gloom, right? Gloom and doom.
And apparently this person who tweeted it is a former professor of evolutionary biology at Evergreen State College. And then...
Right, yes.
Yeah.
Evolutionary biology, that's correct.
He resigned under some controversy and, and has been in the disinformation business ever since. So,
getting this notice, I have a chat message in Riverside. Where is it? Oh, here it is. Welcome to Riverside.
Yeah, it's just a welcome message.
Oh my gosh.
Right. I saw that at the beginning. I was like, oh, what's going on? No, it's just welcome.
We don't need that. April writes, you were musing about why some of you haven't gotten COVID. I have an idea. You guys are working with so many infectious agents over the years that your immune system is turned up. I'm on COVID Island 2. Well, I got it a month ago, so much for that. Alan, you've never had it, right?
Well, I had something during the Omicron wave, and my wife had something, and Sophie had a little bit of a cough around the same time, and we didn't test.
I see.
Because at that point we were all triple immunized, and and my feeling has been, since being vaccinated, my feeling has been, if I need to come to clinical attention because I'm feeling badly enough, then I'll let the doctors test at that point. And other than that, I'm not going to go around swabbing for it and looking for it.
Yeah.
Because if it was, if I'd gotten some kind of a head cold in 2019 and tested, I wouldn't have tested for that. No.
Do you test for influenza when you feel ill?
No.
No. Well, Rich has not had it, and Kathy has not had it, but Dixon and I have. And so I don't think it has anything to do with us having worked in labs.
No.
I just think it's random.
Yeah.
That's all.
I do think that my time in your lab probably made me especially immune to poliovirus infection. But
yeah, I would agree.
I don't know how long that boost lasts.
I think if we did our polio antibody titers, they'd be quite high.
We talked about that a few times in the lab. Like, should we check people when they come to do a rotation in the lab before and after? And
no, we never
got around to it.
If people didn't have a record of being immunized, we would tell them to get immunized. Yeah. But some people come up with their vaccination card, and that's fine.
Yeah.
Can you take the next one?
Yeah, Craig writes, okay, I finally overcame inertia and set up on Patreon so I could become a member after the episode last weekend. I was confused but thrilled to hear your episode with Chiara Mingarelli. I've studied astronomy since before pulsars were discovered, but viruses started studying me decades before I started studying them through your podcast. I was surprised, though, that no one brought up Jocelyn Bell, now Dame Jocelyn Bell Bernal, who discovered pulsars, but it was her advisor who was given the Nobel Prize. She continued her work and has won many honors since then, but she's high on the list of women whose scientific work was not correctly recognized at the time. Okay.
Thank you for that. Thank you for your support, Craig. Yes. We appreciate it.
And by the way, Andy, I meant to congratulate you on that episode, and next time I see Angela, that was wonderful. You know, people tune into This Week in Virology and they're hearing about pulsars. It's like,
because she was Angela's sister, and Angela said, well, let's get her. So, and she was fabulous. Yeah, she's just a great explainer. And many people liked it, judging by the comments on YouTube.
And now for something completely different. Yeah.
Andy writes, I would love a This Week in Gravity and would be a subscriber the instant I could. And please keep doing what y'all are doing because it's great. Andy is in Atlanta. Yeah, so I will try and convince Chiara to do a This Week in Gravity, and it will be her show. We'll produce it, but I don't want to be on it.
And she can say when each episode drops.
That's right. When each episode drops. Alan, you want to take the next one?
Sure. Daniel writes, the holiday season is just so infectious, isn't it? Have a great season and a happy new year, and sends this wonderful set of augur art that has a menorah and several wreaths in different colors, and Merry Christmas and a Christmas tree and a snowman, and there's a Happy New Year.
And all with bacteria of different colors.
All with bacteria in different colors on different colors of augur. Very, very nicely done.
Lovely. Lovely. Thank you, Daniel. That's great. All right, we have two more. Let's do them.
Sure.
Sue Ellen writes, Dear Vincent and TWiV team, after about 6 straight days of rain, today's clear and cold, 49 F, tomorrow more rain. I really enjoyed 962 with the Mingarelli sisters and all that great astrophysics talks. Usually your digressions are more along the lines of gardening, feeding apples to deer, or something else I can easily understand. But this episode was so special. I did not follow all of it, but then I often don't follow all the virology talk. However, it was great to see a smart woman scientist talk about astrophysics. If she starts a podcast, I will definitely be listening. And especially for Rich, I'm sending this link to the Backyard Squirrel Olympics done by Mark Rober, who, as it happens, is an engineer at NASA and also a squirrel lover and nerd. One hobby of his is building these elaborate, very well-constructed squirrel challenge stations. I think Rich will enjoy this, and I hope you all do. So there you go, YouTube video on Squirrel Olympics. P.S. I just caught the 30-minute special episode with Paul Offit. It was outstanding, so much better than the little sound bites you get from most news shows. And, of course, questions from you and Rich were intelligent, not dumb like the ones usually asked by news hosts. I sent the episode on to my family physician because I really think the info is pertinent and will be useful to physicians who are actually making decisions for patients. Thank you, Sue Ellen. And Alan, you can have the last one.
All right, I'll take Katie, who writes, "Hello, TWivers. I've been listening to your podcast since the beginning of the pandemic and have truly appreciated your science-based conversations and clinical updates with Dr. Griffin. The witty banter between you all is entertaining as well. I've enjoyed so many episodes over the past 2 years. Most recently, I really dug episode 960, Getting Funky with Dan Wilson. I now subscribe to his YouTube channel." That was another highlight, by the way, that I was not on. I now subscribe to his YouTube channel and ordered up a Spike t-shirt from vaccinated.us. And yes, I remembered to use the Microbe TV code. Episode 962, Chiara Mingarelli, Who Takes the Pulse of the Universe, was awesome, even though I understood about 70% of the conversation. No worries, though. I shared a link to the episode with an aerospace engineer friend who absolutely loved it. I write in today because at the end of the episode, Rich's pick was a squirrel-proof bird feeder. This reminded me of my son's favorite YouTuber, Mark Rober, and his journey to find a squirrel-proof bird feeder. Mark Rober is a scientist who makes learning about science super fun for my 13-year-old son, and we always enjoy the videos he produces. His squirrel videos are our personal favorites, and I thought Rich would get a kick out of them too. His glitter bomb videos are pretty entertaining as well. Keep up the great work. I really appreciate and love what you all do. And that's another YouTube setup.
So that's the same Mark
That's the
Rober
same.
as,
Oh, yes. Okay.
as Sue Ellen sent with the Backyard Squirrel
Squirrel
Olympics.
Olympics, yes.
Isn't that funny? So
Nice.
he's an engineer at NASA. There you go.
Right.
Well, look at that. We got through all the emails, which we haven't done in a long time.
Yeah.
That's pretty cool. All right, let's do some picks. And what do you have for us, Alan?
I have a book that I just finished recently. It actually came out in 2001, I think. But it just popped across my attention. I said, oh, I've got to read this. It's called A Voyage for Madmen by Peter Nichols. This is about the 1968 to 69 Golden Globe round-the-world sailing race. I know Rich will appreciate this. So, Rich, if you're listening, definitely check this book out if you haven't already. Nowadays, there are these. There's a race called the Vendée Globe, which is a solo round-the-world ocean race, and it's they're televising it from the deck, and they've got high bandwidth internet connections, and everything is done carefully engineered carbon fiber composite yachts and this and that. 1968, they didn't have any of that. And this actually started as basically a dare by a newspaper as a publicity stunt, the Globe in Great Britain. Someone had just the previous year sailed around the world with only one stop by going into the Southern Ocean and then around easterly and then back to England. And so it was obvious that somebody had to go and do it nonstop. And so the Globe put up this challenge. We'll give a prize, and it was a significant cash prize at the time, to the first person to successfully sail around the world solo nonstop. And 9 men came up to do this who had varying degrees of background in sailing, and they had very different approaches to it, and very different boats, and very different tactics. And as the tagline for the book says, 9 men set out to race each other around the world. Only one made it back. They didn't all die, but they didn't all exactly come through in the best of shape either. So I'm not going to spoil who wins, but it's just a really great. I mean, you could Google it. It's a race from 50 years ago, but it's a fascinating profile of these individuals and what motivated them. And Peter Nichols has relevant background. He was a delivery skipper for like a transoceanic delivery skipper for yachts.
Cool.
And then he became a writer, and it's really well written, and I basically devoured it in a sitting. It's a great sea tale.
I guess Rich should read this. Right?
Rich should definitely read this if he hasn't already.
You got that, Rich?
Yeah.
If you made it this far.
Yeah.
So, Alan, you do a lot of reading, obviously,
I
right?
do, yes.
Where do you like to read? Right there in that room?
No, I read in the living room.
In a nice chair?
Mostly, yeah. I've got a nice chair in the living room, a couple of nice chairs in the living room, but just sit there. I've actually, since the pandemic, one of the one of the little habits I picked up is I take one day a week, usually a Saturday or Sunday, and just disconnect from the internet. If something comes up and I've got to check the weather or something, I'll go online for that. But I don't check any feeds or news or anything. I'll read magazines and New York Times book review and paper on Sunday and books.
Cool.
Yeah.
I've been trying to read a lot lately. I usually read on the train. I read on the Kindle, right?
Yeah.
And interesting. I've started a few books lately, and I don't like them, and I get halfway through and I stop. And I usually never do that, but I just bought John Irving's new book, and I can't get through it. I don't like it. I'm a big Irving fan. I've liked most of his work, but I cannot get through it.
Oh.
I just don't like it. And he said it's his last book, so I'm never going to finish his last book.
Oh, okay. Well, try this one.
I will. So I picked up Chiara's pick last week, which was a book about space by it's the Sean Carroll, of which there are two, right? There are two Sean Carrolls, and this one is the space one. So I'll try that. But I've been reading Japanese fiction lately. I do like Japanese fiction.
Oh, cool.
We're like who's the famous one?
Kafka on the Shore.
Yeah, Kafka on the Shore. We can search with that. Haruki Murakami.
Yeah, Laura recommended that particular book of his, which I just read maybe last year sometime. Really.
And so then I got some other recommendations for Japanese authors based on him. All you do is go to the page and you can see, we also recommend these, and some of those are good too. But my pick today is food. It's in particular dessert. It's the holidays, and and I grew up in an Italian family, and a lot of desserts around. And two of my favorites I want to tell you about. Okay, the reason I'm bringing this up is because Wednesday this week on our live stream on our Q&A with A and V, there's a one of our listeners is called Polio Pete. That's his handle. He said, "Do you like pignoli cookies?" And I said, "Yeah, you bet I do." These are lovely Italian cookies. They're made with confectionery. They typically have a very strong almond taste, and then they're studded with pine nuts or pignoli nuts. They're very good. And so Polio Pete said, "We have a great bakery here in Brooklyn," I think he said. And they're $29.95 a pound. Whoa, that's expensive, right, for cookies. But I'm looking, the link I'm going to give you is just a search for pignoli cookies. So you can see that price varies in a lot of places, but they are delicious. So they're kind of like gold, studded with pine nuts. And almond paste is the main ingredient. That's why they taste of almond. And so Polio Pete's actually going to visit the incubator next Wednesday and bring me a box of pignoli nuts from Brooklyn. So that'll be fun.
And these are, so according to Wikipedia, these are a Southern Italian thing mainly. So your family's from
Southern
Italy. Yeah.
Yeah, I mean, for sure. And I grew up with these every holiday. My grandmother would make them, and I really like them. But they're very, there's a lot of sugar in them. So
they're cookies,
you got to moderate. So that's one of my favorite. And then the other one is Pfeffernuss.
We like these around here too. Yeah.
These are small spice cookies, and these are popular with Germans and ethnic Mennonites in North America. They're also made in Denmark, the Netherlands. However, and they can be made in different ways. So in my family during the holidays, they were made with a confectionery coating, a powdery coating, and they're infamous because you would get them all over your fingers.
They make a huge mess.
Make a huge mess. But they're delicious. The ingredients include cardamom, nutmeg, cinnamon, cloves, ginger, black pepper, mace, anise, sugar, butter, eggs, and flour. So it has a very nice cardamom, nutmeg taste. Some people make them with a shiny coating, a white coating also. And others make them with they're just a brown cookie with a little splash of the white sugar on the top. It doesn't have to coat the whole thing. But I like these very much, even though they're not of Italian origin. My family, for some reason, used to serve them every holiday. So
Cool.
I remember those two. There are many others, but those are my two favorites, the Pignoli cookies and Pfeffernuss. So have a good holiday. I guess, what are we at, the 16th? So, yeah, we have another TWiV before Christmas here. Yeah. Which is next Sunday. Okay. All right, that'll do it for TWiV number 965. You can find the show notes at microbe.tv/TWiV. You can send your questions, comments, and you can send your picks in as well. We'd love to get them. TWiV at microbe.tv. If you enjoy our work, please consider supporting us financially. We exist on your financial support, and we are a nonprofit, so whatever you give is U.S. federal tax deductible. You can go over to microbe.tv/contribute. There are a bunch of ways that you can help us. And you can also go to the Amazon Smile program and nominate us as your charity, so they send a fraction of your purchases our way. It doesn't cost anything that way. That's a cool way to do it if you want to select us as your charity. Alan Dove can be found at turbidplaque.com. Thanks, Alan.
Thank you. It's always a pleasure.
And I'm Vincent Racaniello. You can find me at virology.ws. A very short thank you today, just the two of us. And there have been some episodes with just Alan and me years ago.
Yeah.
Right? So the way it worked is I started TWiV with Dixon, and then I just felt Dixon wasn't going to be reliable every Friday. So
he
I
would
said,
be
I
off
need to get
fishing somewhere. Yeah.
Yeah, so I said, Alan, join me. And then, in fact, as soon as Alan came on, Dixon went to India for a month. I'd like to thank the American Society for Virology and the American Society for Microbiology for their support of TWiV, Ronald Jenkins for the music, and Jolene for the timestamps. You've been listening to This Week in Virology. Thanks for joining us. We'll be back next week. Another TWiV is viral.